most position of the condyle, but kindly correct in your notebooks and your in your kindly correct in your books also, in your MCQ books, that the centric relation is not the posterior most position of the condyles. The mandible can be posterior most or the ear most, but the condyle are oriented antero superiorly. Remember this. So if we see the definition, just a minute, I'll just put on the definition. uh, if I show you the definition of GPT is the glossary of prosthodontic terms 1, 2 and 3. So if you see in first definition, they were the most retruded position of the mandible. Please, it is the most retruded position of the mandible, that is correct. But if you see in the later part of the definition, when the condyle are in the most posterior unstrained, please, for God's sake, now the definition is totally changed. The definition, इससे भी ऊपर definition आ चुकी है, but for all practical purposes your GPT-5 gives you the best definition. Okay, so what it says is that it is the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with the complex in antero-superior position. Write down, it is in antero-superior position against the slopes of articular eminences. And mind you, this position, there are a lot of questions within this definition, that centric relation position is independent of tooth contact. It is clinically discernible. Clinically, it is repeatable position when the mandible is directed superiorly and anteriorly, and mind you, it is restricted to a purely rotatory movement. It's a hinge movement about transverse hinge axis. देखो, remember that एक hinge axis क्या होती है? Axis is what? जहाँ rotation होती है, तो earth is rotating around an axis. Same way, the interincisal opening of around 21 to 22 mm of interincisal opening. So there the condyles are rotating and not translating. Remember this. So when the condyles are rotating in the fossa, so they must be having an axis of rotation. That axis of rotation is normally called as hinge axis. But when we are talking about when the mandible is closing, is rotating in centric, the mandible is closing in centric and the condyles are rotating, so there we say the hinge axis is termed as terminal hinge axis. Write down, terminal hinge axis. Okay, so what is the significance of centric relation in complete dentures, or in any in FPD, in everything? It is, write down, it is most orthopedically stable position. We can see that it is most orthopedically stable position. So because we see that all the muscles, the musculature, the TMJ, it is an optimum state of health without any strain. So this joint, for this joint to be orthopedically stable, the condyles have to be in centric relation position. Remember this, that when we talk about the vertical jaw relation, it is tooth to tooth movement, it is tooth to tooth relation. But when we are talking about the centric relation is bone to bone relation. Centric relation is bone to bone relation. Okay, right? So it's an ideal arch to arch relationship where it's an optimum functional position. As I told you that if we are talking about the optimum functional position, so the jaws, the muscles and every musculature is in optimum health in centric relation. That is why we are reading about centric relation. That is why we must furnish our occlusion in centric relation. It should comply with centric relation, right? Then it's a hinge position. That is, the condyles exhibit only pure rotation without any translation. As I told you that, see, every movement apart from centric, if we are taking the mandible in protrusive, it will come back in centric. So every movement apart from centric will terminate in centric. It has to, जैसे नादा गरिंदे घर आ जा, तो वही चीज़ है, मैंडिबल जाएगा कहीं आएगा यहीं, तो they will all return or terminate in centric. So it's a reproducible position. They are coming back to same point. It is reproducible. That is why they will serve as reliable reference point to develop centric. So they will serve as a reliable point for developing occlusion in artificial dentition. That is why it is important. It is reproducible, discernible. Okay, got it? Okay, so it's a position where we all swallow, where the lower and the upper teeth are braced against each other during deglutition or swallowing. Okay, and write down it's a posterior border position. Border position क्या होती है कि जहाँ पे एक्सट्रीम पोजीशन होती है कि अगर मैं मुंह खोल रहा हूँ तो मैक्सिमम यहाँ खोल सकता हूँ, तो दैट विल बिकम माई बॉर्डर पोजीशन. तो अगर इफ माई मैंडिबल इज इन मोस्ट रिट्रूडेड पोजीशन, मैंडिबल रिमेंबर दिस, सो उससे ज़्यादा जा नहीं सकता, तो दैट मीन्स मैंडिबल के लिए तो इट इज़ व्हाट पोजीशन, it is the posterior border position, and it determines the posterior limit of envelope of mandibular motion. Write down, it forms the posterior limit of envelope of mandibular motion. So that is why it is served as a reference for occlusal reconstruction and even in dentular situations. Clear hai? Okay, it's a loading joint position. Right down, it's a loading position. Loading position का क्या मतलब है कि when the patient is eating, the condyle goes in the, it will, if you see the definition, it is the maxillomandibular relationship where the condyles articulate with the thinnest avascular portion. Remember this, that we have three parts of the disc. Okay, the anterior, the middle and the posterior. So the middle part is the thinnest and the avascular portion, and it is non-innervated. So every time when you are eating, when the patient is eating or closing, the condyle disc assembly, the condyle is in the center or the middle avascular portion. It is loading the joint, but the patient doesn't feel pain. Why? Because there are no nerves in the middle portion. If it would have been the case that the condyle is braced against the posterior most position of the condyle, the condyle is braced against the posterior most position of the disc, where the tissues are called as retrodiscal tissues. It is highly innervated. The patient will feel pain. So that is why the condyle articulate with the thinnest avascular portion of the disc. That is the middle portion. Okay. And our joint, because it's a loading joint position, so whatever forces are there on the occlusal table, more than 2.5 times it is having compression at the joint. Okay. Okay, now if you remember that what is the problems in retruding the mandible to centric, when you are recording the centric you feel that there are some problems. Okay, okay. So when you are, because in a complete denture patient, when you are recording the centric, what are the problems in retruding the mandible? Because the teeth are gone, the patient is actually habitually closing to a more forward position. जिसे हम habitual centric बोलते हैं. So do you want to give denture in habitual centric, or the actual centric exists? As I told that it is totally independent of tooth contact. So actual centric position does exist. Actual centric position does exist. So because the patient is closing in, have been closing in such a forward position for such a long time, maybe, So the muscle engrams are taking the mandible forward, and they are already set in. So do you feel that in one appointment or in two appointment you will be able to train the muscles back to right centric? No, absolute no. So what are the difficulties? Because you have to retrude the mandible and you have to direct the condyles to a more anterior superior position. So what are the problems in retruding the mandible? So there are three problems. One, biological problems. Second is psychological problems, and third is mechanical problems. Okay. So when we are talking about the biological problems, we all know that most of the edentulous patients, most of the patients, they may be suffering from some or the other neuromuscular incoordination, or neuromuscular problems like myasthenia, like your Parkinson's, or because of very old age, the muscle neuromuscular problems are there, and other problems. And also, as I told, that biological problem, when the patient is not able to retrude the mandible, is because he or she have been habitually closing the mandible in a more forward position, right? So these are biological problems. These you have to respect these. So it will take some time to train the mandible back to centric. Psychological problems, see, remember, think that if you remember your BDS days, or even for that matter, so when you were recording after the vertical, the most difficult problem was the centric, and your teacher used to say record the centric, और आप जीरो काटा खेलते थे ऐसे, है ना? पेशेंट बार बार मुंह खोल देता था, आप बोलते बाबा जी पीछे ले आके बंद करो, बाबा जी उतने आगे ले आके बंद कर रहे हैं, फिर आप अब 1:45 हो गए, 2 बजे लेक्चर है, and you start becoming irritated, and throw your temper and throw your anger on the patient. बाबा जी मैं बोल रहा हूँ पीछे ले आके बंद करो, आप बार बार आगे ले आके बंद कर रहे हो. भाई wait, patient's engrams, patient musculature has been trained to take the mandible forward. Can in 15 minutes or 20 minutes you can train the muscles back and the patient can close in centric? Absolute no. आप जितना गुस्सा करोगे पेशेंट से, जितना इरिटेट होंगे, क्योंकि पेशेंट आप जितना बोलोगे पीछे ले आके बंद करो, उतना ही पेशेंट आगे ले आके बंद करेगा. तो पेशेंट विल बिकम मच मोर कंफ्यूज्ड. He will never respond to whatever direction and everything you are telling. You lose your temper, actually your patient goes off, gone. You won't be able to record the right centric. So psychological problems. Third is the mechanical problems. Mechanical problem भी बहुत बार होती है. देखो, याद रखो कि आपका सेंट्रिक तभी अच्छा रिकॉर्ड हो सकता है when you have good fitting denture bases. If you have poorly fitting denture bases, then it will be a problem. Then when you have taken the then your heel area should not be an interference. It should not contact when you are recording the centric, otherwise it will be wrong. Then both the sides, when you are closing, they should be equal pressure. They should not be unequal pressure. Now this might happen because of the unequal resiliency of the soft tissues. We learn about real F effect, resiliency, and like effect. The term real F effect was coined by Hanau. So it might be because of the difference in the resiliency of the soft tissue. At some point of time, right side पे ज़्यादा है, left side पे कम है. So it might also affect and play a role in the mechanical problem in retruding the mandible. So how will you assess the patient? How will you train the patient to take the mandible to retrude? We will ask the patient to let the jaw relax, try to pull it back and close. आराम से बंद कराना है, easily on the back teeth. एक बार करोगे, 2 बार करोगे, 3 बार करोगे, ठीक है ना? तो ये सबसे, और you have to give instruction in a very cool and calm manner. ओके, तो अब बार बार पेशेंट को बोलोगे जी रिलैक्स छोड़ो और कोशिश करो अपने पीछे वाले दांतों पे बंद करो, बार बार आराम से धीरे से. तो पेशेंट को टेक्टाइली पता लगेगा, हाँ यार ये क्या कह रहे हैं डॉक्टर. रीइंफोर्स करो बार बार. इट इज़ वन ऑफ द मोस्ट ईजीएस्ट मेथड्स. सेकेंड, जो अगेन इट्स अ मोर इम्पॉर्टेंट मेथड इज दैट इफ वी आस्क द पेशेंट टू पुश द अपर जॉ फॉरवर्ड. कैन यू पुश योर अपर जॉ फॉरवर्ड? नो. In the act of doing so, you actually put your lower jaw backwards. Try doing so. So you actually take your mandible backwards and close. Then we ask the patient to repeatedly protrude and retrude repeatedly while the patient hold the fingers against the lightly against the chin. तो पेशेंट कैन फील, हाँ भाई मेरी चिन मूव कर रही है, इसके साथ साथ मेरी मेरी फिंगर मूव कर रही है. तो ये बेसिकली क्या है कि ये बेसिकली एक अगेन पेशेंट कैन फील कि राइट ये सीधा प्रोट्रूड करने में रिट्रूड करने में कैसा लगता है, राइट. दीज आर द वेरियस वेज. देन वन ऑफ द मोस्ट easiest methods is we ask the patient to touch the tongue on the back of the palate, and we ask the patient to close. One of the easiest method. Okay, so for intrusive record we can use this method also. Okay, then tilt the head backwards and try to close. So these are also the, we can do this, no problem at all. Okay, swallowing, booze, Dawson's bimanual method, normally they are not used and they are not good methods in complete denture relation. So swallowing is a poor method, remember this in CD. Then what are the methods of recording centric relation? Now when we are talking about the methods of recording centric relation, so there are static methods. According to Boucher's, we have static and functional methods. Now how would you take these two methods? One is the static and other is functional. So the static method is basically you have rims, okay, you have occlusal rims, and you just stabilize the rims with the index finger and the middle finger. You actually stabilize the upper rim, and with the right hand you stabilize on the buccal aspect of your lower rim, and you just try to guide the mandible backwards, and with the interocclusal record in between you just guide the mandible into centric. These are the, and you can do it with or without central bearing devices. I will tell you what are central bearing devices. Okay, so static methods are rims हैं, उसके बीच में interocular recording method और आराम से पेशेंट उसमें क्लोज कर रहा है. Functional methods are basically there जहाँ पे mandible is in the function or it is moving. So example, needle house, Essig's, Patterson's method. Now the problem here is that which methods are better methods. So the better methods are the static methods. Remember why? The static methods are better methods. Why? Because the patient is closing into it and there are no leverage forces. There are very less chances that the lower rim or the upper rim might move and give a wrong centric. So in functional methods, because the mandible is moving like this, let it be your chewing in method or Patterson's method, Essig's method, there are high chances, there are a lot of leverage forces on the rims, and there are high chances of getting a wrong centric. So rims should be stabilized, they should be stable while you are recording the centric. That is why I say static methods are much better methods as compared to your functional methods. Okay. Then other methods are also there. Hartwell ने कहा functional, graphic and physiological और tactile और interocclusal record methods. तो there is another. So functional method I have already told you. Graphic में basically intraoral और extraoral devices आ जाते हैं. Then physiological लिख लो, ये आया हुआ है कि nick and notch method is definitely it's an interocclusal method, but it is also physiological or tactile. तो nick and notch method is physiological or tactile. So I won't go into the details of how these methods are, but I will tell you, I will talk in detail regarding the Gothic arch tracing method. But yes, just the names. Functional methods, as I told you, Patterson's and needle house, where it is based on the principle that there might be some styli and there will be some recording media over which the styli will move and it will give some tracing, and at some point you will record the centric, and that you say yes, at this point is a centric relation position. So if you can see, this is one of the needle house method, where on the maxillary rim that is being fabricated in your impression compound, and you have added styli, and the lower rim you have added a flatter surface. Now the mandible will move right, left, protrusive, retrusive, and you can see that this position यहाँ पे वापस आएगा. This shows the centric relation position. So basically again, as you see that here the mandible is moving, it's a functional method. There might be a choice that there might be a problem of leverage forces. Okay. Patterson's method, you see that there's a trough with the carborundum paste. You are just doing the tracing, and you just get the flow of the carborundum paste, okay, disclosing paste or the carborundum paste, and you can just record the centric with this method. Nick and notch, as I told you, now various questions can be asked on Nick and notch method. So if you remember your undergraduate days, you feel that there are a lot of problems when you used to record the centric. Why? Because when the patient, sometimes when you ask not to open the mouth, when the patient always open the mouth, and you have already sealed the rims while you have recorded the centric. So for that method, you actually जितना हम करते हैं, we use a all pin method. हम स्टेपलर पिन्स लगा देते हैं, हम हॉट करके अपना स्पैचुला से उसको वो करते हैं. these are totally are wrong methods. ये सही मेथड नहीं है. Nick and notch method is the rightest method, to be honest. Now in Nick and notch method, what we are doing actually is on the maxilla, you can see we are making nicks. These are nicks जो कि सिर्फ half of the circumference of the buccal area में लगा पड़ा है, and we make notches, and these are notches are made through and through the width of the rim like this. Now and we make, आप इसके करस्पॉन्डिंग यहाँ से लेके यहाँ तक आप मैंडिबल में क्या बनाते हो, आप ट्रफ बनाते हो, राइट. नाउ इफ आई पुट अ इंटरऑक्लूजल रिकॉर्डिंग मटेरियल इन दिस ट्रफ एंड आई आस्क द पेशेंट टू क्लोज, तो कुछ निक में भी जाएगा मटेरियल और कुछ नॉच में भी जाएगा. लेट इट सेट. नाउ इफ द मटेरियल गोज इन द नेक, so you feel that there would not be any mediolateral movement, ठीक है, क्योंकि half of the rim is there, and if you have done this is a mesiodistal, so if it goes, there will not be any anterior posterior to the movement of the rim. And even if the patient opens up accidentally or like this, so you still have the record. So this also act as an indexation, this also act as an index. So even if the patient opens the mouth, you can again reorient the nick and notch and the troughs with the interocclusal recording material, and you don't need to record it again, right? So nick and notch method is one of the better methods. Graphic methods, maximum questions are there on graphic methods. Okay. Right, so then I talk about the graphic method. The graphic method is basically the needle point tracing method that was given by Hesse in 1897. Okay, now we all know that in the graphic method there are various central bearing plate and central bearing point. Now what is this central bearing plate and central bearing point? As the term says, centric means centralization of the forces. So whenever you will do tracing, the central bearing point and the central bearing plate should meet in the middle. Remember this always, because I need centralization of the forces. Remember this. That is why write down, that is why graphic, this is one of the best visual means of recording centric. This is one of the best visual means of recording and verifying centric, because the central bearing, I will just show you what is central bearing point and central bearing plate. So the central bearing point and the central bearing plate, as the name suggests, central, it is basically centralization of the forces, where the maxilla is sitting exactly on the top of the mandible, and the central bearing plate and the central bearing point, they are contacting exactly in the middle. That is why we do tracing in class 1 cases. in Kennedy's in class 1 ridge relation cases. We do not do tracing in case of class 2 where the maxilla is too much forward, so all of the forces will be they will not be centralized and they'll be far forward. And when we are in class 3, the forces are backwards, they are not centralized. That is why if you have to do tracing, you have to select a patient with class 1 ridge relation where the forces are centralized. You cannot do tracing in cases of class 2 and class 3 ridge relations. So the graphic methods, these can either be intraoral or extraoral methods. Okay, even graphic methods can record the eccentric relation, for example the protrusive one and everything. So graphic methods, so write down, these are the most accurate visual means of making a centric relation record with mechanical instruments. Write down, very very important. Written? Okay, so they are the most accurate visual means of making a central regression record with the mechanical instruments. Now if you can see, this is a central bearing plate in the mandible and this is a central bearing point in maxilla. So when they will meet, you can see that if it is in class 1 ridge relation, they will meet exactly in the center. Okay, so now if I have an intraoral Gothic arch tracer, so I just remove this styli, this central bearing point is removed and I'll just replace it with the styli. Okay, तो अब ये चेंज हो गया है हमारा इंट्रा ओरल ट्रेसर में. So the orientation is same exactly. I remove this central bearing point and I just replace it with the styli in the lower arch. Now understand, if I guide the patient, now this is happening totally in the patient's mouth. Can you see what the patient is doing? No. So the first problem with the intraoral Gothic arch tracing method is that you as a dentist, you cannot guide the patient because everything is happening inside. Second thing, the tracing that we receive is a smaller tracing. छोटी, बहुत छोटी ट्रेसिंग होती है and you cannot guide the patient. On the contrary, if you see this, it is a extraoral Gothic arch tracer और इसको हम high tracer भी बोलते हैं. Now this is if you can see, the extensions are extraorally and you can see there is a styli, there is a recording media on the lower end. If it comes out of the mouth and the patient is doing the movements, so the dentist is able to visualize. He can always guide the patient. Close, open, take the mandible. Always the dentist can give instruction to the patient. And even the size of the tracing is big in case of extraoral tracing method. Got it? Got it? So the limitations of graphic method, as I told you, as a matter of fact, extraoral tracing method are better. But what are the limitations? As I told you, you need stability of the rims and the denture bases, so they should not be done in cases of highly resorbed ridges and in cases of your flabby ridges, so which might lead to instability of bases. Now in cases where you cannot attach the tracers, for example the inter-arch distance is very less, how can you attach the tracers? Okay, patient with TMJ problems, class 2 class 3 relation because of difficulty in stabilizing the bases and centralizing the force. I told you that you should not do graphic methods in case of class 2 class 3 ridge relations. Okay, now if we are talking about this various tracings, okay, if we are talking about these various tracings, so normally this is a typical tracing. remember is that the apex of the arrow, the apex of the arrow determines the centric relation position. These are the arms. There is the right lateral position, left lateral position, and the straight line is a protrusive record. It's a protrusive line. So if I take this as a protrusive line, this may be right lateral, left lateral, and the point where all these three meet on a single point, making a sharp apex, sharp and defined apex, it is a centric relation position. Remember this is that the tracing that is okay will have a sharp apex, well defined apex. Otherwise it will be a wrong tracing. That means it shows healthy TMJs without any interferences in the condylar path, and the muscles have a great balanced guidance. Okay. Okay, if you have, this is a typical tracing, this is okay. Now you see in the flat tracing, you see that the arms are more flatter at a more obtuse angle. So what is the cause in a flatter tracing? In a flat tracing, it might be because of marked lateral movement of the condyle in the fossa. Marked lateral movement of the condyle in the fossa. Asymmetrical third, asymmetrical कब होती है? एसिमेट्रिकल होती है जब एक कॉन्डाइल ज़्यादा मूव कर रहा है और एक कॉन्डाइल बहुत कम मूव कर रहा है. ठीक, it might happen asymmetrical movement of the condyles within the glenoid fossa. Then if you don't get a very sharp apex and you actually get a round apex, that means the apex is absent and is more roundish. That means the patient is showing a weak retrusive movement. It should be repeated. Patient training is necessary. Okay, so tracing should be repeated until or unless the tracing is more pointed in nature. That means we need to we need to train the patient well. Okay, then miniature tracing. If you see the miniature tracing, it can be because of the restricted mandibular movement, or it may be also be because of improper seating of the denture bases or painfully seating of the denture bases. Patient is not able to move the mandible so much because the patient is having pain. Okay, and also it might be because के patient ने बहुत time तक edentulous है और आपने उसको कोई डेंचर नहीं दिया तो उसकी मसल्स ज़्यादा मूव करती ही नहीं है. देयर इज इनहिबिशन. पेशेंट को इतनी ज़रूरत ही नहीं पड़ी कभी, क्योंकि पेशेंट ने कभी दांत भी नहीं दिया आपने. देन यू हैव अ डबल एरो. तो एक तो आपका हैबिचुसेंट्रिक का होगा पॉइंट और एक आपका एक्चुसेंट्रिक का होगा. सो इट इज़ बेसिकली दी इफ़ यू फाइंड अ डबल एरो, दैट मीन्स पेशेंट आप हैबिचुअल भी दे रहा है और रिट्रूडेड भी दे रहा है. तो again, patient training is important until you get a single point of centric relation. Okay, ये एक और रीज़न से डबल पॉइंट ट्रेसिंग हो सकती है. ये भी एक रीज़न हो सकता है कि पेशेंट ने बहुत ओवर क्लोज कर दिया और वर्टिकल डायमेंशन चेंज हो गया. अगर पेशेंट ने अपनी ट्रेसिंग में बहुत ज़्यादा ओवर क्लोज कर दिया और वर्टिकल डायमेंशन चेंज हो गया, देन ऑल्सो यू कैन गेट अ डबल एरो. देन डॉर्सली एक्सटेंडेड, वेयर देखो नॉर्मली हम कभी भी पेशेंट का जो मैंडिबल होता है, जब हम whenever we are retruding the mandible, it should be an unstrained position. बट क्या हम उसकी वाली पोजीशन से भी पीछे ले जा सकते हैं स्ट्रेन पोजीशन में? यस. सो इफ यू डू लाइक दिस, सो देन यू गेट अ डॉर्सली एक्सटेंडेड एरो. Okay, then you see break or the loss of continuity of lateral incisor path. This might be because कि आपके posterior rim टच कर रहे हैं, इंटरफेरेंस कॉज कर रहे हैं, या फिर आपकी posterior क्लियरेंस बहुत ज़्यादा नहीं है. ठीक है. Then we have an atypical form. Atypical form, it may be because of the patient is having a faulty muscular pattern. Okay, and the patient is having parafunction maybe, or it might be a very old patient who have been using dentures in an incorrect centric relation position. It might be the problem. So I hope these things are clear and you are able to understand this, right? Now, what is a pantograph? A pantograph is used to clinically to measure the mandibular movement. दो तरीके के होते हैं बेटा, मैकेनिकल भी हो सकते हैं, ठीक है. इट इज़ बेसिकली टू रिकॉर्ड द मैंडिबुलर मूवमेंट इन 3 डायमेंशन. पेंटोग्राफ is basically used with fully adjustable articulators, and it is being used to record the 3-dimensional mandibular motion. If you see the picture of a pantograph, you will see a lot of cumbersome upper jaw, lower jaw, the styli, the flags and whatnot, right? ठीक है. You can use record the recording material for centric. It might be in waxes, impression compound, plaster, ZOE and elastomeric impression material. Okay, but the problem with waxes is that they have a very high coefficient of thermal expansion, and they might be, and they may not be they should not provide any good interocular recording material. They should not provide any resistance to the closure of the mandible. Remember this. So they should be free flowing initially. Okay. So this is all about centric. Let us, in 15-20 minutes, let us also read about the theories of impression making. Okay. So what are the objectives of impression making? So when we talk about the impressions objectives, so these are the preservation, PRESS, preservation of alveolar ridge, retention, stability, support and aesthetics. So depending upon the amount of pressure applied, we have mucostatic, pressureless or minimal pressure technique. Depending upon the compression, depending upon the pressure, mucocompressive. If we are applying a lot of pressure, the mucostatic pressure was given by Harry L. Page. The mucocompressive was given by Green Brothers. Initially it was given by Carroll Jones, and later it was advocated by Green Brothers. Selective pressure, definitely it was given by Carlo Boucher, based on the position of the mouth while making the impression, open mouth, closed mouth. Normally we make open mouth impression, but in cases of relining and rebasing, to avoid increase in vertical dimension, we make it in a specified vertical dimension, so that that is why we make a closed mouth impression for relining, rebasing. Okay. Just very quickly, we will just discuss about the mucostatic technique. Now it is basically being based upon the principles of mucostatics. According to this, basically the major mode of the retention of the denture is interfacial surface tension. So in this technique, if we are basically following the Pascal's law, that means if the pressure is applied to any one part of confined fluid, and if we are pressing, it is liquid is incompressible, and we are compressing it, it is being transmitted equal to all the directions. So the same picture is formed when you have a free flowing material. You have tissues and you have tray, it acts as a closed compartment, and when you are pressing it, so the pressure is equally confined to each and every direction. Okay. So basically if we see the features of this technique, mucostatic technique, because the tissues are being recorded at rest and they are not displaced, they are placed actually, we have accurate tissue adaptation. ठीक है, we definitely we are not pressing, so it might happen that the borders are short, the dentures will have shorter flanges, and definitely we are not doing any border molding, so the whatever retention that we are getting, it is only through the excellent interfacial surface tension, or the intimate contact of the impression material with the tissues. Definitely the seal will be compromised, the retention will be lesser, and the food will go because the borders are very short, lateral stability will be lesser. So these are the one of the problems, but the advantage is that it has a high regard to the tissues, because you're not compressing, you're not causing any change in the soft tissue and hard tissue health. Mainly these type of impressions, they are used in cases of flabby ridges, okay, or where there are severely resorbed ridges. The impression of choice, or the classical impression of choice, is impression plaster. अगर impression plaster नहीं है तो free flowing ZOE, free flowing, light body, these are also mucostatic impression materials. Then mucocompressive, as I told you, the Green brothers came later. Carroll Jones the advocated this theory. So mucocompressive is that mucocompressive, you are compressive the mucosa, and you're recording it under tension or functional pressure to provide that support and retention for the denture. So because we are compressing the tissues, so basically what we are doing, we are compressing it. Later on there might be a rebound effect, and there will be a problem in the blood supply. Ischemia हो जाएगा, transient ischemia हो जाएगा, it will rebound, and when it will rebound, then it might lead to what? It might lead to the dislodgement of the denture, and this should not be even used in cases of your sharp and spiny ridges, because there will be pain. Selective pressure was mainly given by Carlo Boucher. It is one of the most popular methods, and this method basically involves both. Okay? This involves both the it has the features of mucostatics. Why? Because it says that you have to apply pressure on the areas which can withstand it, and you should not apply pressure on the relief areas where you should not, where you should not be able to directing pressure, the pressure. So we direct the pressure on the areas that can withstand the pressure, but we are not directing the pressure on the areas, basically the relief areas, which cannot take it. That is why it is named as selective pressure technique. Okay, so that is why there are primary stress bearing areas, secondary stress bearing areas, relief areas. Okay, so so what is the basic advantage? Because it considers the physiologic function of the tissues of the basal seat. Disadvantage, definitely it is not possible to record some areas under pressure, and some are relieved. So that is why they will have both advantages and disadvantages of both. But still, if you ask me, it is one of the most followed techniques in case of complete denture fabrications. Open mouth, closed mouth, functional and physiologic movements. राइट डाउन एक और चीज़ लिख लो बेटा, फंक्शनल जो इंप्रेशन या फिजियोलॉजिक मूवमेंट से होते हैं, जैसे you are sucking, grinning, licking, swallowing, like this. We ask the patient to the movements. So basically the functional impressions, they write down, they are mainly recorded with tissue conditioners. ये आता है, patient is asked to do such movements. These are functional or physiologic movements. ठीक है, clear? Any doubts? Because if you have any doubts, kindly ask me. I'm waiting. Any doubts? बताइए। Any doubts? So I hope, let us wrap up this session. I hope you have understood, and then next we will take mostly immediate dentures and over dentures in this complete denture series. Thank you so much. Stay blessed. Keep reading. And mind you, again, what I am saying is that the pattern is the old pattern. Again, I am saying, please students, it is the older pattern that is being still followed in this NEET 2025 exam. If possible, I will take another session on this, but kindly, in the last time saying that, kindly do it. The same pattern will be followed. Earlier there was news that there are new pattern on the exam in this NEET 2025. Please, there are 240 questions, 100, 140. There are sections, you can go back, no problems at all. So this is an authentic information. So kindly follow the older pattern of exam as it was there.